Hi, and thank you for joining us right here at Prostate Cancer Live. We're now over 100,000 followers at Google Plus, and we're honored to be able to provide this service for you. Joining me is Doc RBT, Rich Bevan Thomas, out of Arlington, Texas at USMD. Hi, RBT. How are you, man?
Hey, I'm good, Todd. How are you?
I'm doing really well. Look, I think this is an exciting time to be able to help patients. And the first question right off the bat, what is what is one thing that newly diagnosed patients should know? Like right off of the bat, what do they need to know?
So Todd, we've covered this a couple times, but I think it's good to go over this again. So the first thing for patients who are newly diagnosed with prostate cancer, what they need to know is time, for the most part, and what I mean by time, I mean by a number of weeks, is on their side. Weeks and months, for the most part. I think that's the most important thing. If I had to stratify patients, which is the fact of I've been diagnosed with prostate cancer, it's get the information and understand your diagnosis. So, don't get nervous about this. Yes, I get it. And we've got all different grades of prostate cancer and stages that we talked about. But at the end of the day, it is always about time is on your side and knowledge is power. So that's the first thing, Then from there, you take a deep breath and you say, okay, so I've got a little bit of time. It's not like I'm going to be whisked off to the operating room, in a week or even the next day or even the next month for that matter. So then you can try to figure out is, okay, number one, take a breath. Number two is let's find out more about this prostate cancer. And again, I would then go to the classification system that we discussed before, which is where do I stand in those NCCN guidelines. And that's the first two that we talk about in terms of making sure people understand where they are.
Okay, super advice, because I think the big takeaway is it's not all one size fits all, right? Like your prostate cancer is going to be different than your neighbor's prostate cancer. So you got to understand what your specific cancer is like. How common is prostate cancer?
Well, it's common. And again, so the statistics that everybody, pretty much knows about, but we're going to kind of reiterate those today, is that about, if a man lives, until his, late 70s, the risk of developing prostate cancer is roughly about 1 in 6, right? So that's something easy to remember. It increases, obviously, for a couple of different risk factors on here, but that's easy to remember. It's a 1 in 6, man's risk in his lifetime. And how common it is? Well, this year in 2014, there's estimated, and it's been pretty stable, but there's about 230,000 men who are going to be diagnosed with prostate cancer. And that's increased maybe a little bit over the last several years, but that's a pretty fair number of men, who are actually being diagnosed every year. So again, pretty common, from a malignancy-wise, it's the most common, non-skin malignancy in men.
Wow. Okay, that's interesting. Are some men more likely to be diagnosed with prostate cancer than others?
So they are. So, and this is, of course, the big challenge that we've been talking about, more recently, which is that, and I actually just wrote a kind of a long, editorial on this, which is about prostate cancer. Are we over-treating prostate cancer? Are we over-diagnosing prostate cancer, right? And the bottom line is that, several years ago, and I think people still make a very solid argument for this, which is that men who are at risk. So who are those men? Well, number one, and it's pretty easy to kind of go down this line, is number one, men with a family history. So if you had a dad diagnosed with prostate cancer, in particular, your dad who was diagnosed before the age of 65, that puts you at an increased risk, right? If you've had more than one, let's say your dad and your uncle, right, and maybe your dad, your uncle, and your grandfather, then that puts you at an even more increased risk. That's just from a genetic, component of this. So that's it. So that's a family risk. Second thing is African Americans. Unfortunately, and we're looking at from a genetic perspective, African Americans just have a higher risk of actually of developing prostate cancer. And the unfortunate part about the African American side on things is that we as urologists tend not, unfortunately, to get African Americans in the early stages, because for a lot of different reasons, whether it's getting into the doctor on time or whether it's just trying to, the patients for one reason or another can't get to a physician, or they just try to sort of, just try to keep away from urologists. That's a challenge. So we tend to diagnose African Americans at a later stage, and we're doing our best to make sure that we're getting the African American male population in early enough so we can say, okay, we're now finding these men early. And again, if we find prostate cancer early, we can then go through that pathway. And that pathway, of course, is this, if we find cancer, is this a cancer that we need to treat, or is this a cancer that we can potentially follow? So again, review, family history, African Americans, those are the big ones we looked at. It comes and goes whether there's going to be a big risk for men who are actually obese, with a body mass index above 30, and there's been both sides of the issue on that. I personally think that it's not necessarily, and we've had this discussion before, is that you can look like a triathlete, but unfortunately you can actually be very unhealthy on the inside. So you look like $1 million, but you've got so much inflammation going on in your body because you're pushing your body so hard all the time that is actually causing that inflammation. The inflammation, again, is an immune reaction in your body. That then subsequently causes your immune system to it really just doesn't function the way that it should, right? So that's sort of going where you could be a triathlete that just pushes yourself too hard every day, or you could be a morbidly obese male who just, basically just eats, Twinkies and hot dogs all day long. And, they're not necessarily the same group, but those guys, unfortunately, are at increased risk because, we have to look at the potential for those guys from an inflammatory perspective that they could potentially develop prostate cancer.
Yeah, they both have inflammation issues, huh?
Yeah, and that's kind of the big buzzword, that's gone around for a while. And, and we've realized that, inflammation actually causes a lot of things. And, I think what we should do is at a later date, we'll talk about inflammation, how it works, and how there's I think a preconceived notion about what inflammation is, and we'll do that in a later subtext. But at the end of the day, those are the big patients, that we're looking at. And of course, the final one, of course, is age. Is that as a man ages, he increased risk of prostate cancer, and there's a whole host of reasons for that. Hormones start playing a real role in that. Bottom line is that we know that the average age for a man with diagnosed with prostate cancer is roughly 67 or 68 years old. It kind of fluctuates between those, but we'll call it 68 for all intents and purposes. So as a man gets older, he increases his risk as well. So this man is 40s, pretty low risk, and it starts going up and up as he gets older.
So Doc, are you hitting the table a little bit as you're talking? You're a little fired up tonight. So if you could lay off that, because it's just hitting me in the headset, and I'm sure other people are getting it as they're watching. By the way, if you want to submit a question, feel free, and if it fits within the context, I'll bring it up right now.
Today I went to hit the table.
Yeah, right. Today I went and had lunch at Dr. Andrew Weil's anti-inflammatory restaurant called True Foods Kitchen here in Phoenix.
Yeah.
And so it's funny that we're talking now about obesity and the triathlete, how they both have inflammatory responses going on in their system. And so it's interesting, how it all plays out. Look, symptoms of prostate cancer comes up a lot. People might think that, hey, I don't feel symptomatic, I may not have a problem. What should men know about symptoms?
Well, the problem is that there are very few symptoms, and we've said this time and time again, is that the problem with prostate cancer is you don't feel it. You can't feel a bump in your prostate. You can't feel that your PSA is elevated. So let's take a stroll down memory lane before the advent of the PSA, which was, again, in the late 80s, early 90s when we started using this. And at that time, men actually would feel some symptoms. They'd get lower back discomfort, or they'd start having some voiding symptoms. And unfortunately for those men at that time, roughly about 1 out of 5, about 20% of men actually, when they presented, they actually had a palpable nodule and a bump on their prostate, right? So, and then we diagnosed them with prostate cancer, and then we would get a bone scan on them, and we would actually find that those patients actually had, metastatic prostate cancer. And so they were symptomatic, but they were symptomatic because, again, they had cancer that got outside the prostate. So in the early phases of prostate cancer, you're not going to feel much. And what happens is that we try to make it simple for patients. So, when we say that, you don't have any symptoms, you really don't have any symptoms. But sometimes they'll say, okay, well, you have slowing of your urinary stream, or you feel like you're getting up at night. And those are the symptoms for what's called benign prostatic hyperplasia. So that's what we call, the sort of the enlarged prostate, for lack of a better term, right? But really, that's significantly less common than actually somebody who just walks in and says, I don't feel anything, Doc. How can I possibly have cancer?
Right. I totally get it. Okay, Doc, I just got a question submitted from a gentleman in our audience. His name is Mike. Mike asks, do you have an opinion on Vietnam Navy veterans that are now being diagnosed with prostate cancer? Is it possibly that the cause is Agent Orange? What are your thoughts on this?
So that's actually a great question, and I've actually seen numerous men actually with who've been exposed to Agent Orange, and there actually is, and I'm pretty sure about this. Don't quote me on this, but there is a set of symptoms for these men, and prostate cancer, if they develop prostate cancer, is one of them. And again, I don't work for the VA, but I'll tell you is that there actually has been several research studies that actually show that men who were exposed in Agent Orange in Vietnam, because we don't use this anymore, although some people would say that if you go to some of the if you go to some of those Slurpee places, it looks like they're putting Agent Orange in those things, that toxic FDA dye stuff, but the bottom line is that the Agent Orange stuff was really toxic stuff, and the bottom line is that stuff actually was so toxic that as these men have now, as they've grown older, and obviously these men, this was in the in the 60s and early 70s. What's happened is these men have developed a little bit sort of like the 9/11 thing, is that all those toxins have actually built up in their body, and we actually have seen those patients. I worry about the patients who actually have been exposed to Agent Orange with developing these high-grade cancers like these Gleason 8s, 9s, and 10s, and so I tell people the following. Is that if you are exposed to Agent Orange, again in Vietnam, I think it's more important than ever to make sure that you do get screened, for prostate cancer, which is the regular way that we do it. We do a PSA and we do that rectal exam, but I would definitely make sure that we're doing it every year and really watch that elevation of that PSA. I will tell you that the rectal exam, at least in my opinion, is really important on these guys because unfortunately, sometimes these really high-grade cancers actually are behind the PSA producing one. So in other words, that PSA can be like 1.5, then it goes to 2, then it goes to 2.5, and then they say, oh, don't worry about it. That PSA's fine. It's below 2.5 or it's below 3, and it's all good. And you feel their prostates, and you feel a real hard nodule on there. So I think it's very, very important. And whether it's that. Again, I think the rectal exam is vitally important on these guys because, again, I think these tumors have a propensity of actually developing high-grade tumors.
What's the texture like, a normal texture when you're examining it? What's an abnormal texture?
Yeah, so what we learned in medical school, and it's pretty similar to that, is that when you're actually feeling your thumb, I don't know if you're going to feel like this. This is sort of what a normal prostate, kind of feels like this, and so it should feel like, a little bit sort of, a little spongy, but not too bad, it's what we call the thenar compartment right there. But if you start feeling, if you feel your knuckle, right, you feel that kind of knuckle right there, that's when you actually feel a nodule. And, that's when we start getting worried, when we start feeling a real hard bump on there.
Wow, that's really interesting. Okay, another question just came in from Stuart. He says, Doc, if I have a family history and I'm at high risk, what should I do and at what age?
So that's another great question, and herein lies the debate of when we actually start this. And even the American Urologic Association, which is our association for urologists, continue to debate this. I think that most urologists will tell you right now that if you have a significant family history, you should start either at the age of 50, and I personally recommend in your 40s. And I'm going to tell you why I actually think that why men with a significant family history should get a PSA in their 40s, right? Because, and there's great studies out on this, is that let's say a man's got a positive family history that we just talked about, and he walks into my office and says, hey, Doc, I'm 44 years old, I got a positive family history, what should I do? And I say, well, let's screen you. So we do a rectal exam, it is what it is, we get it done, we make sure we don't feel any bumps. And then we get a PSA. So now let's look at that PSA. That PSA for that man is vitally important. Here's why. There's a cutoff that we know. So we know if that man's PSA is below 0.6. Let me say that one more time. If that man in his 40s is PSA below 0.6, I can tell him, listen, Mr. Jones, you know what? Your chance of developing a malignancy, a prostate cancer, in the next several years is extremely low. So I'm okay with seeing him in 2, 3, or 4 years, I probably every 2 to 3 years, because of a significant family history, and doing another PSA at that time and doing a physical exam. I'm okay with that, right? Now, let's say he comes in and his PSA is 1.2. That's a guy that may not have a focus of cancer right now, but we know that because his PSA is above 0.6, that he is at increased risk, and that's a guy that I want to follow earlier before, you start looking at the age cutoff, 50, 55 years old, what have you.
Okay, really, really interesting advice. the next question on the list is, how can a patient be comfortable choosing to not treat their prostate cancer? And I think before you even get to that point, do some patients have the option to not treat their prostate cancer? Sounds a little crazy.
Yeah, so, and again, we've talked about this before too, and the bottom line is that, the first thing we do, remember, the first thing we do, a man's diagnosed with prostate cancer, first thing is take a deep breath, and let's try to figure out, let's get some knowledge here. And as opposed to going on, some hokey guy's, website that's, trying to sell, snake oil from the Amazon jungle, let's find legitimate, websites that actually, that talk about, true science about prostate cancer. That's part one. Part two is, how do we classify those patients, right? So again, we look at that Gleason grade, what is the grade of that cancer? And if it's a low grade, and again, the Gleason 6 is what we describe as the low grade. If it's a low grade and described as a low volume, and again, I would defer to our other conversations that we had in terms of classification of these men in terms of the very low risk and the low risk categories. That's the risk of progression as time goes on. So for those men, the possibility is, we could potentially, with low grade, lower volume prostate cancer, we could potentially follow them. Now, let's go into the detail real quick. So how do we follow patients? Do we just say, all right, man, give me a call in a year, let me know how you're doing, make sure you're peeing okay, and that's fine? The answer is no. Because we know that of that one time that we do that biopsy, that is basically just a sample. And we know that there is, of the men that we actually follow with these low-grade prostate cancer on what we call active surveillance, and active surveillance means we're actively following these patients. So, and again, there's different protocols out there, but most protocols basically involve a biopsy. The year of biopsy, we have that original biopsy. We say you got low-grade, low-volume cancer, and we're going to follow you, right? So we say, all right, we'll follow you. And then what we do is we do sequential biopsies at years 1. At USMD, we do it at 0, at years 1, years 3, and years 5, and every 2 to 3 years thereafter. And a lot of it depends on their age. So as they get older, above 75, then we really try to minimize the number of biopsies, right? But we also follow their PSAs. So the two things that will pull these patients out of active surveillance is, number one, is if we rebiopsy those patients and all of a sudden they get reclassified. So we all of a sudden we see like a higher grade disease, like a Gleason 7 or 8, 9, or 10. That automatically we will tell those patients, look, and there are some exceptions, but we'll tell them, you know what, it's time to start considering treatment of this treatment. You don't have to, but we got to consider treatment, right? And the second thing is if we see doubling of that PSA within 2 to 3 years. Now, the doubling time, again, is a little bit dodgy. That still is debated, with Dr. Larry Klotz, who's over in Canada. But the bottom line is that those are the two rules for that, in terms of pulling those guys out and making sure that they're not going to get into trouble.
And how does a test like the Oncotype DX test fit in? I know that my wife is a breast cancer survivor, and the Oncotype DX test in breast cancer helped us make the determination that her cancer wasn't aggressive, and therefore it wasn't. It was indicated that chemotherapy wouldn't be of benefit in her result. How does a test like that play in, like the prostate assay that they've created, into the treatment decisions that you make with active surveillance? So
it actually plays a pretty significant role. And and the challenge is that we're making decisions on this man's prostate cancer, solely based on a biopsy, of which we may be, undergrading that if there is another cancer sitting inside that prostate, as well as, actually classifying them again into that very low risk, intermediate, or high risk. Again, those NCCN guidelines. Bottom line is that we can get more information and we can actually put them. Think about that scale. So we've got very low, intermediate, and high risk. And what the Genomic Health and the Oncotype DX test does is it actually looks at the genetic makeup of that man's particular cancer cells, and it tells us the likelihood that it will behave like either a very low, intermediate, or high risk. And that's actually very important for us, because what it does is then individualizes that man's cancer to let us know is what is that risk. And you get a percentage, you get a GPS score, and again, we've talked about this before, but it does give us more information, and it just, again, any bit of information that we have can then, give us a little bit of a pause to say, okay, we've now got the genetic makeup of this, so this isn't just, every Joe with a Gleason 6 with 3 cores that are positive and a PSA density of 0.14, they're all the same, because they can, be a little bit different, and it depends on where they lie on that range from very low to intermediate risk, that we say, we might want to consider treating this. Again, a guy in his 40s or 50s, a guy we're going to be potentially more aggressive with. Some guy who's older, maybe is in his 60s and 70s, that's a guy that we can potentially follow. So it just individualizes their cancers.
Really, really well explained. Thank you for that. Well, he's Doc RBT out of USMD in Arlington, Texas. He's our medical advisor right here at Prostate Cancer Live, and so if you guys have any questions for further interviews, feel free to submit them. We'll review them. We may not be able to answer all of them, but we love to get questions answered by the doc when he is here. So on behalf of Doc RBT and the team at Prostate Cancer Live, we wish you all a very healthy and happy evening, and we look forward to bringing you more information as it develops right here at Prostate Cancer Live. Doc RBT, thank you so much for joining us.
Great. Thanks, Todd. Appreciate it.